Okay. Good morning, everyone. I'm thank you for the warm introduction, Shirley. I'm really happy to be here today. I wanted to start actually by thanking all of you, the Miles for Migraine community. I'm still pretty nervous about public speaking, but I'm here today because I've seen so many of you, migraine patients, with the Miles for Migraine, getting up on stage, completely owning how nervous you might be. And I've seen many people just bravely keep on talking anyway. Many people who've had really important things to say. I also wanted to thank Shirley for inviting me. We started brainstorming topics for this a few months ago, and she asked me if I would talk about pain reprocessing therapy, that there was some interest in learning more, understanding more about that intervention. The more and more I started planning in my head, how would I present pain reprocessing therapy, the more I kept coming back to some of the basic pain science concepts that I think are important for understanding that treatment, but maybe some other ones that you're familiar with as well. So I hope by listening to this talk today that you'll gain a better understanding of your treatment options. Okay, I was told if I pointed it this way, it would work better. Oh, there we go. Okay. Oh. So my goals for today are to explain why pain science is relevant to migraine, to review a few of the basic concepts, to provide a framework for understanding non-drug treatment options, and to discuss some research findings as well. If we have time, if I can talk fast enough. So I won't go too much into migraine. I think Caitlin and Dr. Young have done an excellent job, but just pointing out that as we all know, that migraine is more than just a headache. It involves altered processing of sensory stimuli, and that prolonged and repeated attacks of pain can seriously affect daily activities of people living with migraine, and even exacerbate various symptoms such as nausea, vomiting, photophobia. It can impact pain associated affect. So those are the emotions that you experience related to your pain or your migraine. Common ones are depression and anxiety. And those can further contribute to headache-related disability. Frequent attacks can exacerbate pain and elevate heightened risk of physical disease, psychological comorbidities, and all of this together can impact both health and quality of life for people living with migraine. So migraine is a central nervous system disease. It's complex, as we all know, and the underlying pathophysiology is not completely understood. We do have some evidence that over time, repeated attacks of head pain result in both structural changes and functional changes in the brain. And Dr. Young had shared an interesting slide as well about the frequency of attacks predicting progression to daily headache. So some of these changes will include changes in gray matter volume, altered functional connectivity, and hyperexcitability of the brain networks. These can impact pain perception, central sensitization, allodynia, cognitive functioning, emotional functioning, and sensory sensitivity, just to name a few. Furthermore, this is pretty interesting fact, I thought, was that these changes can impact the person with migraine even between their migraine attacks in what we call the interictal state. So I have a little analogy to help us wrap our brain around what does that actually mean when I say structural changes and functional changes. So we can break this down. So think of this phone, or think of your phone as a brain. In this picture, we can see that the hardware of the phone and the software of the phone are both working great. Now let's think of this phone, that the phone starts to get headaches. There could be some hardware problems like a cracked screen or maybe the SIM card gets wet. Some of those problems would be visible to the naked eye. Others would be pretty easy for the technician to identify with their diagnostic tools. But what if they find nothing obviously wrong with the phone? And you come back and say, I don't understand. None of my, that's great, but none of my apps are working. That's the functional changes that we're talking about. And our everyday experience in life, both the function of our body and or both the structure of our body, but also the functional way that our body works is pretty important. So you can think of structure as the hardware and function as the software. Both of which are pretty important to the overall functioning. And this is real, right? It's frustrating. Even if the phone seems to be perfectly, the hardware is fine, it's frustrating when my app's not working. It's frustrating when I can't get into my bank account to pay one of the bills. That has a real impact. And so I put a little joke. I hope this lands well with everybody, that because I'm a psychologist, but I'm sorry to be the one that has to tell you, but I think your phone might be crazy. And I just included this little quote by Joan Didion, who was an American writer and journalist, because I think it really captures the sentiment of this as well. So I'll read it to you. For I had no brain tumor, no eye strain, no high blood pressure, nothing wrong with me at all. I simply had migraine headaches. And migraine headaches were, as everyone who did not have them knew, imaginary. Okay, so let's dive a little bit into the history of pain science. To do this, we're going to travel back 400 years to a theory by a French philosopher named Rene Descartes. He gave us the idea of mind-body dualism. And basically, this states that the mind and the body are separate and distinct. Relating mind-body dualism to the experience of pain, we get the specificity model, this Descartes' specificity model, in which the experience of pain is specific to the site of injury and to the level of damage. So here's a little example of that. So here the person has sprained their ankle. The tissue damage is detected by the nerves at the site. They send a signal from the peripheral nervous system to the central nervous system up the spinal cord. That signal then gets received by the brain. And in this model, the ankle is telling the brain, ouch, it hurts, I'm in pain. Okay, so this looks a little bit complex, but I promise I'm going to walk through this and it will make sense. So today we know, in 2025, we know that pain is really not that simple. Pain is not just the physical sensation. It's not always proportional to the tissue damage. It also involves emotional components and cognitive components. And pain, the body doesn't tell the brain what hurts. The brain tells the body. So looking at this chart, you can see there are some yellow numbers and some blue numbers. So yellow numbers represent the ascending information. So that's information that the body is sending up to the brain. And the blue numbers represent descending information. So that's information the brain is sending back down to the body. And they communicate with each other, obviously, very well all day long. So I'm going to give an example of stubbing my toe to help explain this concept. Unfortunately, I've done this many times. I'm a little bit clumsy. So I've just trying to walk from one point in my bedroom to the other. There I go. I've knocked my toe on the dresser. My toe sends a signal up to my brain. We can think about that as a bottom-up signal. The signal starts from the bottom, goes up to the brain. That message gets to my brain. The first place it goes to is through the somatosensory cortex. You don't need to remember that. Just the idea that that's where the brain decides what location of the body is hurting and what kind of pain is this. Is it because it was too hot? Is it sharp? Is it like a mechanical pain, a throbbing pain? Almost immediately, that signal then travels through the limbic system. And I'm going to zoom in here. Through the limbic system, where the brain decides, how do I think about this experience? How do I feel? And when I use the word feel in this context, I mean emotionally feel about it. So for me, I know I don't like it. I know that stubbing my toe hurts like the dickens. The signal also goes through the hippocampus, so my brain can decide, have I ever experienced any pain like this before? Is this a huge threat? Am I in danger? Is there any harm, or does it just hurt? So fortunately, because I've stubbed my toe enough, my brain knows I'm not in harm, there's no danger, there's no saber-toothed tiger, but I do know it's gonna hurt like the dickens for the next couple of minutes. Once the brain has packaged all of that information together, it takes that signal, sends it back down to my toe. That's called the descending pathway, or bottom down, top down processing. That information gets to my toe, and then my toe starts to hurt. So that all happens within a matter of a second. By the time my toe is hurting, all of that has already occurred. Okay. So this is important for understanding some concepts like the gate control theory. The gate control theory helps us to understand that there are gates along that pain pathway that can be open or closed. When a gate is open, the pain signal can travel freely through your nervous system. So think about that like the volume dial in your car, where you can turn the radio up. When the gate is closed, think about that like turning that volume dial down. Why is this important? A lot of the behavioral and non-pharmacological treatments that we have target the areas that we can control, or we can influence, and we can modify, that can help open or close the pain gate. So let's walk through a couple of these. Some of the factors would include physical factors. So things that can open that pain gate, make pain worse, are things like degenerative changes, muscle tension, physical deconditioning, stressed breathing. But there are also physical factors that can help turn that volume down. Things like medical interventions, massage, exercise, mind-body, things like yoga, tai chi, and qigong. Again, we learn that part of that pain signal comes from the way we think about it. So thoughts like catastrophizing, focusing on pain, focusing our attention on pain, having negative thoughts like migraine has ruined my life. These are things that we know can turn that volume up, open the gate. In the other direction, turning the volume down, we can challenge negative thoughts. We can use coping statements. We can work on having balanced thoughts. It's not all about making everything positive, especially not making things unrealistically positive all of the time. That doesn't work. But balancing positive, negative, and neutral. and doing so realistically. As we learned in the way the brain processes and interprets pain, our emotions, our affect, our feelings are a part of what creates the pain signal. So when we have negative emotions like sadness or anger, stress, worry, and anxiety, even despair and hopelessness, these negative emotions can amplify the pain, which then cycles back to generate more negative emotions, which can make pain worse, which can generate more negative emotions. And the cycle goes around and around. But we do know that positive emotions can have the opposite effect. Happiness, joy, contentment, being calm, activating relaxation states. These can all help to turn that pain dial down. Behaviors like underactivity or overactivity, you're going to hear again and again, I'm sure. Lack of involvement in hobbies, even that pushing through it and pushing through it and pushing through it and then crashing. Those are behaviors that we know open the gate, turn the pain dial up. Better ways of coping using our behaviors would be using pacing strategies, increasing pleasant activities, taking your medication, taking it early. Those are things that can help turn the pain dial down. And we also know that our social interactions make a big difference. Social isolation, being getting a lack of support from others, sometimes even getting too much support from others, and stigma can all have that negative effect, increasing pain. And positive time with family, volunteering, community involvement, belonging to Miles for Migraine in its many capacities, including its support groups. Those are all things that can help turn the pain dial down. There are some factors that we can't control, like our genetics or aging or the weather, but there are many factors that we do have the ability to influence, to modify, and to have some control over. Okay, so we started 400 years ago with Descartes, and now we're fastly moving forward to what we now know is the neuromatrix model of pain. This kind of puts together all of the things that we've just talked about that we know in today's day and age. So that circle in the middle is the body self, and it is comprised of cognitive factors, our thoughts, affect, our emotions, and sensory, the stimulation that our body feels, our sensations. I find it to be pretty interesting that we use the same word feeling to describe our sensations as we do to describe our emotions. I think really speaking to how that mind-body dualism didn't really make a whole lot of sense. One of the things to keep in mind with this neuromatrix, again, my goal is not to have you memorize all of this, but one of the concepts I want you to take away is that what fires together wires together. So sometimes we can have a physical sensation, let's say head pain, and at the same time, if we're thinking, oh, wow, that really hurts, I hate this, it's completely awful, that those things get wired together. And so overall, the perception of pain is really an output from the brain. And it's based off of not just the input from the toe, in my example, but from the entire experience. The input from the body, the sensory input, the emotional input, the cognitive input, the memories, all of that gets packaged together to impact the way we perceive pain. Again, turning the volume dial up or down. Our action programs, voluntary and involuntary. So an example of that would be if I've stubbed my toe and I blurt out a curse word, that's an involuntary action program. If I've stubbed my toe and I start pinching or rubbing my arm to distract myself, that would be a voluntary action program, something I've chosen to do. And it also impacts the way we regulate things like stress and emotions. Okay, so I want to give you a treatment framework because I think there are a lot of biopsychosocial treatments available. Um, and I thought instead of just presenting on pain reprocessing therapy, it might actually be a lot more helpful to give a framework to understand the variety of non-pharmacological treatments. Okay, so I want to start by saying that non-drug treatments are not just comfort measures. So we're not just targeting quality of life, but these treatments can actually trigger a series of positive changes within the peripheral nervous system and also within the central nervous system. So like medical interventions, we're targeting some of the same biological mechanisms in addition to targeting things like comfort and quality of life. Okay, so if we look at a variety of these non-drug interventions, we might be able to categorize them across three levels. The first level down at the bottom, level one, is physical or physiological responses. The second level is psychological processes, so our thoughts and our emotions. And the third level would be a dissociating from physical experience. So thinking about being immersed in a VR headset or over time becoming highly trained at meditation to be able to step away from your physical experience. As I was practicing this presentation with my husband to make sure that it actually made sense to another human being, he added this kind of understanding of the framework, which I actually thought was really good. So in level one, he said to him, that seemed more like the kind of things that we do in the moment. So things like exercise or getting acupuncture or getting a massage. Those are happening in the moment. Level two, it was like the way he made sense of this was that more out of the moment. So as humans, we have the ability to think about the past, the present, and the future, not just to experience exactly what's happening to us in the moment. And a lot of our thoughts and our emotions flow back and forth across those states, past, present, and future. And then at the very top, this more out of dissociative experience, he was like, that's, to him, it made sense to think of that as more out and out of body experience. Okay, so we're going to talk about things that fall under level one, the physical and physiological category. Starting with basics like movement. I like to use the word movement more than exercise. I was always a nerd, so I preferred being in the library to ever being in gym class. So when I hear the word exercise, I'm kind of like, oh God, I hate that stuff. But it's not exercise in and of itself. Movement is what we're really looking at. And if we're moving by walking, if we're moving by going up and because I need to run upstairs and get something, movement is what matters the most. And if you love exercise, continue to think of it that way also. So in the movement category, it could be exercise, physical therapy, and even any physical activity. Exercise is aimed at improving or maintaining your physical health. That can help with deconditioning or keeping yourself, instead of deconditioning, it's keeping yourself conditioned. And like Dr. Young said, movement is medicine. I'll just give a couple of examples. Again, any kind of movement or physical activity is great and excellent. Pilates would be a form of controlled movements that focus on strength and flexibility and also core stability. Aerobic exercise involves sustained rhythmic movements that increase the heart rate and breathing for an extended period of time. And these help to keep our cardiovascular system conditioned as well. The next level one category of interventions is body manipulation. So thinking about these would be things like massage, acupuncture, uh, and I think biofeedback I'm putting in this category. Um, Acupuncture is a traditional Chinese medicine, which involves inserting needles. Um, Massage is another form of pain intervention. It involves manipulation of soft tissue. Massage is generally safe, but I did want to just mention that in rare conditions, it can lead to minor adverse events like increased muscle soreness or stiffness. One of the things about massage to note is that the results are often short term more than they are long term. Oh, I'm going to go back to acupuncture. So acupuncture is based on the concept of qi, which is believed to be a vital life energy. By stimulating specific points, acupuncture aims to balance the flow of this qi and relieve pain. And while acupuncture fundamentally relies on somatosensory stimulation, so that's sensory stimulation, to activate neural and psychological pathways. Thank you. Its therapeutic events are further enhanced when we get into level two things like psychological elements inherent in the treatment experience, such as patient expectations and that ritual of care. Biofeedback is another intervention, and that's using some equipment to learn information about what's going on in your body. So I like to say that we've all done biofeedback. If you've ever used a thermometer to take your temperature, you're doing biofeedback. You might know, oh, I'm not really feeling great, my head's feeling warm, but you wouldn't know to be able to tell your doctor, my temperature is 102.5 without that equipment. And that's what biofeedback is in a nutshell. Biofeedback in the office, you would get hooked up to different sensors that measure the physiological responses that we know to go hand in hand with the stress response, to be able to both learn more awareness of your own body's response to stress, but then also to learn more about what interventions help you to self-regulate. And in this level one category is also neuromodulation, which was already talked about in length, but I've got a QR code. There's a nice little video that goes over some of the FDA. My list is not as extensive as Dr. Young and Caitlin's was, but it goes over some of the FDA cleared devices for migraine. Next, we're moving into a little bit of a gray zone. So these are interventions that target level one and level two kind of together. So mind-body interventions, which can include things like yoga, tai chi, and qigong. I have a couple of QR codes to the Miles for Migraine programs where you can practice these. But let me tell you a little bit about them. Yoga is a mind-body intervention that focuses on physical postures, breath training, and meditation. And studies have shown that and indicated that yoga can increase experimental pain tolerance. So that's when pain is created in a lab. But that it can also produce neuroanatomical changes, so those structural changes, such as neuroprotective effects and alterations in the good direction, alterations in gray matter volume. Tai Chi is a traditional Chinese mind-body exercise practice characterized by slow, flowing movements and an emphasis on balance, flexibility, and mental focus. Qigong is an ancient Chinese practice that utilizes coordinated movements, breathing techniques, and meditation to balance the body's vital energy, which we heard about during acupuncture. So this is also to balance that vital energy known as qi. One of the different ways to think about that would be if the treatment being active versus passive. So acupuncture is a passive treatment. Somebody else is doing the treatment to you, where Qigong is an active process. You're doing the treatment to yourself. I thought it was really interesting. There was a meta-analysis that showed that Qigong is effective in reducing chronic pain when compared to placebo. They compared it to sham Qigong, where the participants had the same body movements, but they did them without the meditation and without the breathing exercises. And that made a difference. So doing all three, oh, thank you. Doing all three, movements, breathing exercises, and meditation together worked better than doing just the movements alone. Okay, level 2, the mental and emotional. So these are what we would think about as psychological therapies or treatments or interventions. These are typically delivered by a mental health practitioner and can be, sometimes can be 8 to 12 weeks. Sessions are typically about 60 minutes. Increasingly, there are more and more trials coming out looking at different delivery methods, such as single session therapy sessions or even self-paced interventions. So thinking about following along with an app. So I'll talk quickly about cognitive behavioral therapy. And again, I only had 25 minutes, so I've got a couple of QR codes where you can listen to a 3-minute talk and an 18-minute talk that shares more about our cognitive behavioral therapy if you're interested. Cognitive behavioral therapy is, or CBT, is well-researched. We know a lot about it. It's the most well-researched psychological intervention. The goals include reducing pain-related distress and optimizing physical functioning. CBT addresses pain management, but it also targets broader domains such as emotional well-being, functional capacity, sleep, and interpersonal skills. In addition to primary treatment outcomes related to pain, CBT has also been shown to help improve secondary outcomes such as self-efficacy, psychological distress, and return to work. ACT, which is acceptance and commitment therapy, entails cognitive, behavioral, and mindfulness-based approaches to increasing psychological flexibility and to living a value-driven life. Applied to chronic pain, ACT helps people engage in value-directed behaviors despite ongoing pain and discomfort, especially when previous attempts to control or reduce pain have been unsuccessful or counterproductive. MBSR, which is mindfulness-based stress reduction. These are interventions that teach patients strategies to focus on the present moment and to develop a non-judgmental awareness of their experience. Applied to chronic pain, people learn to reduce their judgment of suffering associated with pain. Mindfulness-based approaches can reduce stress and improve pain management by teaching these skills so that patients can learn to do those things independently. And the QR code here takes you again to Miles for Migraine, where Dr. Rebecca Wells walks through a mindfulness meditation. Okay, EAET is emotional awareness and expressive therapy. So this is a more recently developed treatment that focuses on addressing unresolved emotional issues and interpersonal conflicts through structured emotional awareness and experience exercises. This is a method to reduce both pain and stress. And it's been studied primarily in processes where they're neuroplastic processes, so things like fibromyalgia or unexplained chronic musculoskeletal pain. So thinking more of the software programs rather than the hardware programs. EAET can also treat anxiety, depression, PTSD, trauma, and stress-related disorders. And finally, I saved the best for last, the one I was asked to talk about, PRT, which is pain reprocessing therapy. This was developed with the goal of retraining the brain to reinterpret the signals, that it gets the signals that we might perceive as painful signals, and to work on reinterpreting them as non-threatening. So building on other pain neuroscience education approaches, it focuses on challenging beliefs about the nature and threat of pain, and it introduces chronic nocioplastic pain as a reversible pain-generated signal rather than a sign of physical injury. Level 3, which is this dissociative state, you can think of this in two different ways. Dissociative meaning kind of an out-of-body experience, but dissociative can also mean immersing yourself in something else. So immersing yourself in a conversation with a friend, immersing yourself in a virtual reality environment. And this technology is getting studied more and more, and has lots of promising, the results so far look very promising for having a good impact on pain. I wanted to mention, I think one of the important things when we hear the word meditation, if you're doing a meditation and you've done it once or twice, you're doing meditation that's hitting a lot more at levels 1 and 2. To get to a meditation where you would be experiencing this level 3 out of body experience requires just more time and practice to really get into it. I'll super duper quickly just go over the bonus, which this is from level 2. The reason why I didn't include it originally is because I don't think that these are treatments that are widely available. So things like open label placebo. Here's an example of one where they were studying open label placebo compared to Maxalt. So you can see that there's black, so that the black dot at the top, that's patients who received no treatment. Blue is patients who received placebo, and there were 3 groups. Everyone received placebo. Some people were told they were receiving the placebo, so that's open label. Some people were told you're receiving either Maxalt or placebo. Some people were told they were receiving Maxalt, but they weren't. And the red is for participants who all got Maxalt, and they were given those same 3 conditions. They were told that the Maxalt was actually a placebo. They were told that the Maxalt, they might be getting the Maxalt or might be getting the placebo. And they got Maxalt and were told they were getting Maxalt. And you can see that the way information that was communicated to them had a big impact on the efficacy of the medication. So very quickly, the overall Maxalt was superior to placebo for pain relief, which is a good thing, which we knew about Maxalt. And this showed that again. The efficacy of Maxalt labeled as placebo and placebo labeled as Maxalt were actually similar. So that was one of the surprising findings. The efficacy of the open label placebo, so you have a placebo and you're told the thing I'm giving you is a placebo. That was superior to no treatment at all. So relative to no treatment at all, placebo under all of those conditions accounted for more than 50% of the effect. And the takeaway from this is that the increasing positive information boosts the overall response. And so the way that the information that is provided to you by your providers is important. The information that you provide to yourself, the thoughts that you repeat to yourself, the scripts that you repeat to yourself are really important. The ritual of taking a pill is important. There are many factors that are important to your important components of your care above and beyond just the active drug component. And I will leave, I don't have time to read through this, but this is an example of a cognitive behavioral intervention script that will be available to you on this slide deck. Thank you very much.
Okay, thank you, Dr. McCray. We are going to have lunch now. It's a working lunch. So we're going to come back in exactly 15 minutes. We're running behind schedule, but that's okay. So please go. There's 2 lines. You can go out that door right there. And we'll see you back in a few minutes. And somebody did leave their map, the migraine, on the table and did not put your name on it. So if you were up here earlier, please come up here and check. And please put your completed forms now up here right before we come back from lunch.